Welcome back. So I clap at the beginning of every week's Maiden Lane Medical Women's Health Weekly conversation. Welcome back this week to our amazing YouTube audience. You guys have been absolutely fantastic in bringing us questions, in offering topics. We are really excited for this week's topic. I want to add a couple of things to the introduction this week. We have now started to make available to all of our viewers and now our listeners the audio content of our weekly Women's Health weekly telecasts as podcasts. So those podcasts are available on iTunes, they're available on Spotify, they're available on Google Podcasts, they're available on Anchor, and about 7 or 8 other platforms. So we're really excited to be able to offer that content and make it easy for people to listen on the train or wherever else they might happen to be. I don't think there are that many people taking the train these days. No. So I want to introduce our two awesome guests today. I want to introduce Dr. Terri-Ann Bennett, who is a specialist in maternal-fetal medicine. That's perinatology for those of you who want to get technical. A specialist in maternal-fetal medicine at the NYU-Langone Medical Center. The brief story is that I've known Terri-Ann since she was an intern and a fantastic resident at NYU, and I'm really, really proud to be able to spend some time talking to her today and with her and hear her opinions and hear her and have her join us as an expert in a topic that I'm very clearly not an expert in, and want to have that opportunity to hear her voice and pick her brain. I also want to introduce to you Dr. Shoma Dada-Thomas, who is a member of our team here at Maiden Lane Medical. Dr. Dada-Thomas is a minimally invasive pelvic surgeon and joins me in taking care of women with chronic pelvic pain at Maiden Lane Medical. So we have an interesting topic today, and I was telling a friend about this topic, and he said, well, that's a very timely topic. And I said, well, it's not, though. It's not a timely topic. What we're going to talk about today isn't new. What we're going to talk about today, which is racial and ethnic inequalities in healthcare, isn't a new conversation. It's not a new topic. It's something that doctors and public health experts have known about for as long as it existed. And unfortunately, some patients have known about it as well. And because it exists. And our professional organizations know about it. And but one of the issues and one of the challenges that we're going to talk about today is how we operate in healthcare as part of a much broader social and environmental atmosphere of racial and ethnic inequalities and injustices. So what we were talking, Dr. Bennett and Dr. Dada and I were talking prior to this starting, and I want to lay this out there. I want to lay this out for our viewers, and I know both of you want to hear this as sort of a launch and kickoff. It's a great way to kind of kick off the topic. There has been a significant amount of attention brought to this issue in the area of injustices or inequalities and injustices, but inequalities in our justice system. And it's no secret that those existed long before recent events and much longer, potentially even than we knew about such inequalities existing in our healthcare system. But Dr. Dada-Thomas made a very interesting comparison. He said everybody's heavily, and this issue came much more to fore because of recent events, but there are a lot of very heavy protests around the country about the death of one person, which is a death of one person in a long line of deaths of other people who shouldn't have died at the hands of our justice system. But she made the comparison very, very astutely, I thought, that I think, and I agree with you, that pales in comparison to the number of deaths and injuries that are the result of very, very similar inequalities in our healthcare system. So with that, and with that understanding and framework, I'm going to ask Dr. Bennett um, a question. What are inequalities in healthcare in general? What's the big picture there? And what do I even mean when I'm asking? What do I even mean when I'm talking about that?
Very similar. Yeah, absolutely. So first of all, thank you for having me on today. I'm I feel very privileged to be here to have this discussion with everyone, because health disparities in women's health is really a passion of mine.
Dr. Bennett, hang on one second. I think one of you has your either like a dual microphone on, or somehow we're just having some mild audio issue because I'm hearing me in the background there.
First of all, thank you for having me on today. I'm very here to have this discussion with everyone.
Is that coming? Are you guys hearing that in the background?
It's really a passion of mine.
That's a little bit of a problem. Somehow we're just having some mild audio issue because I'm hearing me in the background. Are you both able to hear me now? I'm sorry about the audio issues. We normally don't have audio issues. Is there a way for you guys to turn your audio down significantly? Yeah. Okay. Well, I guess we'll continue and try to get over the audio issues. This is a new problem. So anyway, I'm sorry, Dr. Bennett, I interrupted you. I had asked the question, and we had started off with this topic: what are inequalities in healthcare in general, and what do I mean when I'm even talking about that?
So for one, health disparities, just like you said, is not new. It's definitely something that we have been plagued with in our society for decades, if not centuries. And in the general definition of health disparities is usually seen as differences above and beyond those that can be explained by differences in your health status between groups. And in short, it's basically pointing to where Black and brown bodies have a higher chance of poor outcomes, which we know spans across all different healthcare fields, but particularly in my field of maternal-fetal medicine, where we know for sure that there are different aspects of maternal morbidity and mortality that are more common in our Hispanic and our Black and African American women. So when we say health disparities, we mean there's a difference in outcomes, whether that be in a poor outcome or even the worst outcome possible, which is maternal mortality.
So that makes a whole lot of sense. Is one of you running YouTube at the same time? It sounds like somebody's got the YouTube telecast going at the same time. So if that's the case, then we have to turn that off. Either of you, just shake your heads no if you're not running the YouTube telecast at the same time. No? Go ahead and just shake your heads if you're not. Are either of you running the YouTube telecast at the same time? No, I can't. I'm trying to figure out the audio problem. This is such an awesome topic, and what we're gonna lose is a little bit of the background with the noise. Okay, so let's keep rolling here. So does this affect women? Because this is a Women's Health Weekly program. Does this affect women as much as it affects men, or is there a greater or lesser effect on either side of the gender divide?
Well, I'm a women's health doctor, so I can really only speak expertly to how it affects women's health. But also being a Black woman and coming from a Black family, I know for certain that this spans not only to affect women of color, but also men of color as well. Because the bigger issue is that there's a systematic and a systemic plague within our healthcare system that's affecting Black and brown bodies regardless of gender. And I think that's something important for us to recognize, especially people that are not of color, that there's a systematic issue that we are all playing a role in that's causing poor outcomes for men and women who are Black and brown.
All right, so we're going to get into some very specific questions about some of these healthcare inequities and inequities in women's healthcare, and especially as they're related to how they affect our outcomes. But so this is, as part of, there's a baseline inequity for everybody. And that baseline inequity is that doctors know more than patients, right? There's a knowledge gap. So let's say we eliminated the knowledge gap. and patients knew what doctors knew. We're still going to be left with the systemic racial and ethnic inequity. I already know the answer that's going to come from either one of you. Do patients have any control over that? And I use the word that, like, just you have to tell me what that is. Do patients have any control over that particular situation?
Well, I think fortunately right now, one thing we can say is that patients have a lot more access to information. And I'm very impressed with a good deal of my patients across all ages and demographics who come to me having already done a lot of research. And I think one, that's just because we have more access for information. I think that also maybe there are women that realize I have to educate myself on these issues so that when I'm hearing options, I can make an educated guess because perhaps they don't know if the provider is giving them all the options that are ideal for them. So I do think it's an issue that when I've had this discussion with patients and other doctors, and I think there is whether unfortunately or not, there is a lot of responsibilities for patients, especially what we're seeing is perhaps also, especially on women of color, to really gain an education on their own before speaking with a provider and maybe speaking to multiple doctors to find where they're having the appropriate conversation and one that really fits for them. And I say that especially because a lot of the studies that we're seeing are, even when you're taking the issues of access and socioeconomic groups off the table, and you're seeing equal levels of education across the board for patients, even in groups of educated women, we're still seeing disparities of outcomes. So we really have to look beyond just access issues and chronic health care as being the main issues that are causing race disparities. Even when we're removing those, we're still seeing them. So in a very roundabout way, I'm seeing, what I'm saying is that the patient education right now is more important than ever, even before approaching a doctor, and hopefully access for information is helpful in that way. And a good point for doctors as well to think about their conversations with their patients and how they're counseling people, and if that's always an equal discussion, if they're always presenting all the options available.
So when we do research on health outcomes and we control for all variables other than race and ethnicity, we still see health disparities, and that's my understanding.
Oh, yeah. So I can speak to that for sure. I mean, we all know as physicians, especially if patients do their own research before they come in and they have some understanding of their medical condition, it definitely goes a long way. But if you've sat through any health disparities lecture before, a lot of times we're saying it's important about the education level of the patient and it's important about the socioeconomic status of the patient. We put the onus back on the patient, but we're forgetting that as doctors, first of all, doctor means teacher. So a big part of our role is to teach our patients about their medical condition, to help them to come to an understanding of what needs to be done for their improvement. But most importantly, just like you mentioned, we know that when we control for those confounding variables, education and finances being paramount, that we still see poor health outcomes, especially for Black persons. And that's just to prove that it's not race that's the risk factor, it's racism in many regards.
Yeah, for sure, because and then we mentioned this kind of earlier in our sort of pre-talk conversation, is the role of biology and genetics. That doesn't account for it either, because we also understand how to treat biological and genetic factors. So if that were the issue, then it would be almost like a poor practice of medicine issue. That's not the issue either. So then you're only left with the conclusion that there's a built-in racism associated with the care that we're giving black and brown patients, black and brown women in particular. I want to put this part out there, just to get an answer and to see if either of you guys know the answer. And before we get into some of the nitty gritty on the other topics, what can someone do? What can a patient do practically, if either in the moment or in an episode of care they feel they are being treated inequitably, And that inequitable treatment, actually, we forget about their race. That inequitable treatment that treatment is different than the treatment that somebody else is getting. How can somebody, was there an authority to go to? Is there a reporting mechanism? Is there, other than, speak up? What are the things that people can do?
Yeah, I think patients don't realize how much power they have
I think you're right.
and how really take into account the patient experience and how that's even an important factor when you're ranking hospital systems, even nationally. It's a huge percentage of how hospitals are ranked in our nation. So I think if patients don't realize how much power they have and that there is a reporting system to report physicians that they don't feel are giving them the best care or has discriminated against or showed bias to them explicitly during their process of trying to get health care. In addition to that, there's a lot of patient advocacy groups and patient advocates throughout at least major academic centers where patients can not only sort of fight this battle on their own, but there's someone within the hospital system to help to get your complaint out and to help you to, find some resolution when you feel that you've been wronged in the healthcare system.
There's so much to talk about on this topic. I want to hit, and I don't want to treat any of these parts of the conversation superficially. So we might save some of these other topics for another time. But just very quickly, one of the core systemic historical issues in how we treat black and brown patients in healthcare, how we offer them healthcare, is associated with the very, very, very long endemic history of inequity in healthcare research, in clinical research, in drug trials, in test trials, you name it. There, and only until, I want to say, 25 years ago, was was very widely accepted to include all racial and ethnic backgrounds in research. So if you think about what forms our basis of knowledge and progress in healthcare, it's all this like decades and decades of research. And if you look at a textbook and you like pick out the research studies in a textbook that all three of us have probably read, you could probably recognize, and if you looked at those studies and found out who they did those studies on, you're like, oh man, 98% of the patients were white, white females. And the conclusions aren't necessarily generalizable to a different socioeconomic or genetic demographic. And I think that's really important for everybody to understand, that when we're even beginning to address a conversation about racial and ethnic inequalities in the way we take care of women in the United States, we're standing on a mountain of data that doesn't necessarily apply to the treatment we give to this population. All right, so I want to go into Dr. Bennett's wheelhouse. I want to pick your brain on this, and I know you're expert in this. So if you could, for Shoma and I, because Shoma and I don't deliver babies. Neither of us are involved, and there might be a good thing. We leave it to the experts. Neither of us are involved in obstetrics at all, but we do have a general understanding of some differences in maternal morbidity and mortality in certain areas. Can you give me a couple of those areas that are particularly worrisome in differences, in racial and ethnic differences in maternal morbidity and mortality?
Absolutely. And I do want to speak to the first comment that you had about research. We know for sure as scientists, clinicians, and researchers that Black and brown bodies are usually not represented in a lot of major studies to the degree that is representative of the population, which then makes us question the generalizability to these populations. But the other thing to that, and sort of my new catchphrase, is that Black is a big box. Like there's so much diversity within the color or the race of Black, just as there's so much diversity in what is considered a Latina, just as there's so much diversity even in what's considered woman, whether you're considering hetero or trans women. So it's very important that we're paying attention to the fact that these categories that we create are also huge boxes that have diversity even within them. But when we're talking about the lack of diversity in research, I think it's very important for us to recognize why that exists. And there's two things that sort of play a big role on that. And I think it lends right into your second question as to why and what are the outcomes that are poor for Black women. For one, we have to say their names. A lot of this is historical. Some Black and brown people are really not, they're not trusting the medical system. They don't trust their doctors. They don't trust hospitals. And that stems from decades, if not centuries, of just being mistreated. I mean, we have to call their names: Lucy, Anarcha, Betsy. These are women who are operated on without their consent, without pain medication, even when anesthesia was widely used. I mean, we have to call it out. It's the Tuskegee Project, where we know that there was men who were followed just to see like what would be the natural progression of syphilis, and how that creates extreme mistrust in people even accessing medical care. But even bigger than that, it really, when Blacks are really starting to make a stride after slavery and Jim Crow, it really, turned things backwards for us and really reverted a lot of our progress. And it's Henrietta Lacks and how her cells were used without her permission. And even to this day, her family will get none of the billions of dollars that people have made off of her stolen body parts.
Yeah,
that plays.
Dr. Bennett, I forgot about that story, but it's a very prominent injustice in they took her cells without permission and used it in cell lines to develop incredibly lucrative pharmaceuticals. If anyone out there is interested in that story, the Henrietta Lacks story, check it out, because it's an incredible tale of injustice, unethical conduct by many. I'll give you before you go into the conversation about maternal issues, I'll share an anecdote. But I want to just take a quick stop and thank everybody for joining us here on Women's Health Weekly. Experts from New York City and around the country. We are Maiden Lane Medical. Please join us on our podcast. Please subscribe to our YouTube channel. I'll share an anecdote with you, Dr. Bennett. When I was a resident, so a lot of Black women don't trust their doctors. Shoma and I have seen this over and over again. We have a large population of women we take care of with fibroids, and a lot of them are Jehovah's Witnesses. So we see this population, and we often spend a tremendous amount of extra time with them, hopefully getting them to trust what we're telling them is accurate. But the anecdote I'll share with you goes all the way back to 1996 or 7. So I was a resident at Holy Cross. I was a resident at George Washington University, and I was doing a rotation at a hospital called Holy Cross Hospital in Maryland. My chief resident was a woman, a doctor named Leslie Nurse. Interesting, Dr. Nurse. She was a Black woman, probably one of the kindest, most friendly, knowledgeable. She was the administrative chief resident. And if any of you have done an OBGYN residency, the person who becomes the administrative chief resident is typically thought of as the best. Out of the group of 9, she was clearly the best of them. So I was on this rotation with Dr. Nurse, and her and I went into a room to see a patient, and the patient, of course, instinctively, and even though Dr. Nurse was clearly leading the conversation, I was standing there with my arms folded, and she called her nurse. I think maybe because it said nurse on her badge, but when Leslie explained to her that she was the chief doctor on the team, she said, the patient said to her, and I'll never forget this: "I don't want a Black doctor taking care of me." So it turns out that sometimes, and hopefully this is a rare event, but sometimes patients don't trust, Black women may not even trust Black doctors. How are we going to get them to trust white doctors if they're not trusting the healthcare system as a whole? So there's precedent for everything we're discussing. This is all very real. If you don't trust your doctors, then how are you going to get good healthcare? Because our patients are our healthcare partners. They're partners in getting better and preventing illness. All right, so I digressed slightly from what I really wanted to discuss and get Dr. Bennett's expertise on, were issues associated with morbidity and mortality in maternal health care.
But you know what that makes me think of? it has to be our responsibility to gain their trust.
That's right.
We can't just say, oh, she's not taking her medications because she's non-compliant. She's non-compliant. It's sort of like a write-off. You're like, I told her, she's not doing it. She's just non-compliant. I think we have to take the next step. The onus has to be on us. It is our responsibility to gain her trust. It is our responsibility to explain it to her in terms that resonates with her, that's specific to her culture, that's going to make her understand why it's important to take her medications. It's our responsibility to get her over the hump of the mistrust. That's on us.
I'm sorry, go ahead.
Yeah, I'm just glad that you both mentioned and recognized that you're taking care of a lot of minority women and realizing that, hey, there's a mistrust here. But the question is, what are you going to do about it? And I think this podcast is a part of figuring out what are you going to do about it, because it's our responsibility.
Yeah, and you bring up the issue about, and I don't, again, something we don't want to necessarily focus on, but it's a very clear part of this because we really want to talk about some of the systemic issues today. But you bring up the issue of cultural competency, and that doesn't just go for Black and brown women. I mean, this goes for Asian women and American Indian women and areas where the predominantly white medical culture doesn't necessarily understand where people are coming from in other cultures, and very specifically why they wouldn't take their medications. Well, I told her. Why wouldn't she take her medication? Well, because you needed to put it in a different context, and maybe people in that culture don't take this kind of medication for this kind of condition, and there's a workaround. So I'm sorry, Shoma, you were saying something.
Sorry to cut you off. I think for the context of this discussion, to your point about patient education, I think we have to step back and look at our own education and re-education as doctors. I think a term right now that we're hearing a lot is implicit bias. And at this point, the numbers are really screaming out to us about racial disparities in healthcare. And if you were to individually ask physicians, do they have these, are they part of this problem? Are you biased in your treatment? I don't think anybody would really be able to recognize how they're doing that outright. So I think now is really the time to go beyond the macroaggressions and really look at, okay, I have to be part of this. If our system is suffering in such a big way, I have to be active and look for implicit biases. And these are things that are part of maybe daily conversations and recommendations that obviously we're not as cognizant of, and this is a good gut check that it's time to do that. And it's a very hard conversation to have with each other as colleagues, and I think an even more difficult discussion to have to ourselves. But I have been seeing, thankfully, a lot more discussions, and even within hospital training programs. And I saw an article on out of Harvard about training doctors with implicit bias and how to recognize that. And I think a big part of that came about. Sorry to again stall your discussion, Terry, but because a lot of the complaints, and you're definitely going to get to this in maternal mortality and even just treating women in general, is they're saying the right things. A lot of these women are telling you, hey, I have I'm heavily bleeding after my delivery, or you know what, I have this headache, my blood pressure is this. They're saying the right things, but how we're listening to it and receiving the news and processing and then formulating a treatment seems to be a major issue. And so I'm going to stop stalling you, Terry, because I know you have lots of thoughts on this. But I just wanted to bring up the implicit bias issue, which is important for us to look at.
We all need to recognize and accept that we have bias and check yourself. And then you got to take it to the next level, and you have to check your partners. You have to check your residents. You have to check the staff. Like, we have to do a 360 check system within our medical system in order to ensure that we're providing the best care and realizing and recognizing that we have bias. I think racism and bias has just been like such a dirty term, and no one wants to accept that they may have benefited or behaved in a racist way or have been biased. I'm a woman of color, and I will explicitly state that I have biases. We all have them. And I think until we recognize that and then take the steps we need to take in order to combat those things, then we're just going to end up in the same place that we've been. Even as women of color, I recognize that there are still a lot of cultural competence that I need to learn. Yes, I'm Black. I'm also Caribbean. I was born in Jamaica. So I have that experience, but that's my experience and it is limiting. So when I'm taking care of, let's say, my Asian women. And I recognize that there are things about my culture that's different than her culture. There's things about how I would explain something that I think is clear and makes sense, but that may not be clear and make sense for her. So how I check myself is I have a medical assistant who is of Asian background, and she helps me. Sometimes I bring her into the conversation, and then I check myself with her. I say, hey, how could I have explained that better? Hey, do you think there's another term that I can have to accept what it is, because that's the only way we're going to learn and be better for our patients.
Yeah, I think everybody has a sense of that with regard to leadership in healthcare. And I think, fortunately, there are well-thinking and well-meaning and what I like to use the 2020 term woke individuals who are. Do I need to go to Brooklyn to say woke, or am I allowed to say that in Manhattan? I have to go to like. Do I have to go to Williamsburg or Dumbo to say woke? But anyway, there are people in prominent leadership positions who understand and are working as best they can to make those changes. For example, the folks at Harvard, but I know that at NYU and Cornell and the major institutions around New York City, that this type of leadership with regard to working to change how we see people who are not us is in action. All right, can I steer back? Maybe we talk about this time. We want. There's so much to unpack in all of these topics that we could literally have spent the entire conversation talking about cultural competency, or we could have spent the entire conversation talking about sort of the systemic injustices, and even just we could have spent the whole conversation just defining those injustices and those inequalities and how those exist. And we started off the conversation talking about how healthcare and so I'm stealing from Dr. Dada, who kind of made this suggestion in the first place, but how healthcare probably kills far more people in an unjust, inequitable way than the justice system's built-in racial and ethnic inequalities will ever do. And that's because of data we have associated with morbidity, mortality across many different populations and many different disease conditions. But I'll use that as a segue to bring us back to Dr. Bennett and specifically to discuss maternal issues in either preconception issues or either peripartum issues or just gestational issues associated with inequalities and how those play out and how those hurt women specifically.
Sure. So we know for certain, and there's data to support this, that Black women are more likely to have a fetal demise, preterm birth, as are Hispanic women, fetal growth restriction, where the baby is very small for the age, mortality for certain, hypertensive diseases like having chronic hypertension, like high blood pressure or preeclampsia, as are our Hispanic women, obesity, as are Hispanic women, late entry into prenatal care, as are Hispanic women, and more likely to undergo a cesarean delivery. And those are just general obstetrical outcomes. There's also a huge list of looking at sort of severe maternal morbidity indicators. And we know for sure, I mean, I can go on with this list forever, that
Please do.
Black women are more likely to have a myocardial infarction, a heart attack, more likely to go into respiratory distress, more likely to need a blood transfusion, more likely to go into cardiac arrest, have a heart attack, more likely to bleed, more likely to need blood, more likely to need a hysterectomy where you lose your womb and are unable to have future children due to complications of pregnancy, pulmonary embolism, blood clots in the lungs, DVTs, deep vein thrombosis, which can also travel to your lungs, your heart, or your brain and kill you. So these are just really significant things that we know are plaguing Black and brown bodies more. And on a national level, the CDC recognizes that Black women are 3 to 4 times more likely to die than their white counterparts. And when we look at the New York City numbers, Black women are 12 times more likely to die than their white counterparts in data in the past. And though we think that number is improving and we're waiting for the most recent data to come out, we know that the gap is wide. And so we have to look at what are interventions, what are things that we can do to sort of, eliminate these health disparities is really our goal.
Hold it. You just said, I'm gonna put an exclamation point on this. You just told me that Is this black women or is this black and brown women are 12x in New York City?
Black women. This
So
is data
black,
from
so
a year ago.
so black women are 12 times. So there's a baseline level of this. Women do die during childbirth. Obviously, that's something as OBGYNs we would love to never see happen. But across the planet, there is some baseline level of maternal mortality. So you've said this. I had no idea the number was that high. I knew there was a difference very clearly, but I had no idea the number that high. Terry's giving me that face like, Levy, dude, yeah, come on, man, it's that high. So it's 12 times the rate
It has
of.
been as high as 12 times. It's been improving most recently as New York State itself has improved some legislation. Cuomo has passed some legislation. De Blasio has passed some legislation, and they're putting money into the system. One really great program that I think will have a big impact is there's a doula program through Brooklyn where the government will pay for a doula for women of color who need that extra support.
Tell
And
us
I
what
think
a
it's
doula does. Tell us what a doula does for someone in this regard, because it's important.
so, I think it's funny because out in the world, I think there's like a thing where they think like doctors, we like to do doctor things and we're all about like the hospital and intervention. But even as a high risk doctor, I should fall in that category. But I think it's very much important that we complement one another. And so a doula, in sort of layman terms, is a support system for a woman throughout her prenatal care, actually, and during the process of giving birth. And they can be someone to help to remind you what you wanted your birthing experience to be like, someone who can advocate for you, especially at times when probably you're in pain and unable to advocate for yourself. But they are really just like a friend, a support person who's going to have your back and help you to be okay and to have an uncomplicated pregnancy and delivery. And I'm a big advocate for a support person, whether that be a family member or a doula or both, because especially for Black and brown bodies, we need as much support as we can get, to be quite frank. And whatever is going to allow you to feel comfortable and supported, that's what needs to happen. Because even perception of discrimination has been shown to lead to poor outcomes.
Yeah, it's sort of like when you speak of, it's how do people feel about the care environment, and a lot of this goes to, we talk about behavior in the hospital, we talk about what environments existing in the hospital. We know that, for example, in an operating room, poor behavior in an operating room leads to worse outcomes. Well, the surgery is not different. Well, it's how the staff is interacting and working as a team. That, if there's anxiety in the environment. So yeah, even the perception of mistreatment that's racially and ethnically motivated is has the potential. It makes total sense. So I want to go back. I want to stick. I think for the rest of the time we're going to stick with maternal morbidity and mortality because there's so much to unpack there. Does the New York City, because New York State's a very liberal state. There is a government that is basically. I'm sorry, you can't not go to politics here. Yeah, we just have to. There's a government that's basically call them progressive or call them, the Democrats. They're sort of left-leaning Democrats between Cuomo and De Blasio, and when they work together, the state really does great. So they've passed legislation. How do other states fare against New York State? Just if you could speak in general terms about legislative activity for helping resolve some healthcare disparities, but also with regard to maternal mortality.
So this information actually is very public, so anyone can look this up. The CDC usually has, and March of Dimes, they're very good at this, and the American College of Obstetrics and Gynecology, they have these maps of the United States where you can click on your state and you can see what are they doing in order to prevent people from dying during childbirth. And you can literally, the states are ranked. So California is number one. And to be quite frank, a lot of us look towards the California Collaborative in reference to their safety bundles, which are these packages that they have created. And this is recommended from a national level from all of our national societies, where we're now seeing that the standard of care just isn't met all the time. And we know that moms in certain hospitals have poorer outcomes than in other hospitals. And so, all hospitals are not created equal, as all doctors are not created equal, unfortunately. But how do we bridge that gap? And that's education of our doctors and making sure that we're meeting the standard of care. So one of the reasons why our number is improving from that 12 times for Black women more likely to die than their white counterparts in New York City is because we have done some important interventions. And some of that is our safety bundles, which is basically where the national societies that sort of govern how we function in obstetrics and gynecology put together what should happen if, let's say, you had a high blood pressure, a very severe, very high blood pressure, what should happen? And they will literally list out an algorithm. You should get this medication. Your blood pressure should be checked in this amount of minutes. Then you should be getting this medication if it's still high. So they basically try to create a map of how to standardize care so that we ensure that every woman, regardless of what hospital they're in, regardless of who their doctor is getting the same care, what we know to be best practices.
It's
So
sad
that's
that
one initiative. Huge.
it's sad that people have to die in order to create these types of improvements. One unfortunate example of that, but something that turned out to be very positive in the long run, was the precedent event to the 1986 Emergency Medical Treatment and Active Labor Act. And if you're familiar with that piece of legislation, it's a piece of federal legislation that guarantees access to emergency department care, and makes sure that proper evaluations are completed in the emergency room before someone is discharged. And the reason that legislation first came about was a black woman showed up to an emergency room, basically in active labor, and because of the racism, the overt and horrible racism in the emergency room, they didn't take her. They didn't want to treat her. They sent her away to the black emergency room. And this is another part of the country that in New York, than New York. They sent her away to the black emergency room, which was 2 full hours away. And I can't remember the rest of the story, but one of them died. It was either the mother or maybe both of them died. But it's a terrible, terrible story. But it's hard when I think about the mortality rates and then ensuing legislation. I think, God, why do people have to die in order to wake people up? What can't we just say? People are going to die if we don't do this. Let's do it. It's just.
I mean, seriously, I agree with you. I mean, it's a sad reality, but it is a part of our reality that something bad has to happen in our society for us to take action.
Yeah,
in all
aspects of our society.
In all aspects, yeah. I mean, even more recently than that case, in 2017 is sort of where I think maternal mortality got a big push on a sort of national level, and that was because Kira Johnson died. And who's Kira Johnson? She was a very accomplished businesswoman. She's someone who we should think is of the higher socioeconomic status that shouldn't succumb to what we think is a poor or uneducated issue. But she spoke 5 languages. She raced cars. She was the daughter-in-law of a judge, a very popular judge, actually, Judge Glenda Hatchett, and she still died in childbirth. And she had her partner with her, who was advocating for her as much as he could, but she basically died from a hemorrhage. She bled out after having a C-section, after she delivered her son, Langston. But her husband has really been such a strong advocate for maternal mortality, and they ended up passing the Preventing Maternal Deaths Act in 2017, which is coming through our Congress and our Senate. And I think that also then trickled down to a more state level and even in a city level. Because then, like I said, Cuomo passed an act and de Blasio made an act that's given $12.8 billion. It's a $12.8 million initiative that he launched to sort of create a comprehensive plan to reduce maternal deaths and life-threatening conditions in childbirth for women of color.
I think also, you're talking about why do people have to die to change practices. I think that just emphasizes how important it is in our field, where racial biases in our field, just like with the justice system and policing, for what we're seeing, we have to remember that the implications for our field are costing lives. They're not costing dollars. They're not costing, loss of sales or products. And while those things are important, when it happens in our field, we're losing women, we're losing men's lives. And so that's why really this is an elevated topic, because the stakes are much higher.
Dr. Levy, I think this one you're going to like because I follow you on social media. But I think a big part also of why moms are dying is access. And so, believe it or not, even though I gave you some alarming New York City rates, there's some areas in America where your rate of dying as a Black woman is as if you delivered a baby in Rwanda. And that's a fact. And that a lot of that has to do with access. And I think, unfortunately, it comes down to a lot of times the insurance companies and what they will cover. But there are some regions in the United States where women don't have access to a high-risk doctor like myself. And I think that's why I'm such a big proponent and of telemedicine, and how I think that would really revolutionize the way we're able to deliver care. Because there should be no reason why, just because someone's in that particular city, that they cannot speak to a high-risk doctor and their doctor be guided in how is the best way to save that woman's life. And so I think telemedicine is a big wave for the future that will help us to create better access and better outcomes for women.
I'd love to talk about that access topic because you would think, you mentioned having access to people like yourself here in New York City who are at really great institutions, and there are great hospitals, but yet I see every day women of color, Black and Hispanic women who don't have access. I get the emails from our website for women from women who of course we advertise our services, and I get emails from women through our website about needing and wanting treatment for fibroids with heavy bleeding, or endometriosis with severe pain. And those women don't have necessarily any insurance at all. And they, of course, can't pay us out of pocket often. And we do sometimes venture to offer as much care as possible to them. But there's always in those patients the need for surgery, and then they can't afford to get surgery. So the access issue doesn't just exist in other parts of the country. I would say that New York City, in spite of the best efforts of the New York City's public health system, still has very, very significant access issues.
Yeah, there's definitely more work to be done, even on that level.
Shoma, do you see the same thing in patients that would otherwise like to access a specialist or expert in a certain area, and they just can't because those experts don't? We've done our best, and I think a lot of people in our field have done our best to accept as much of the insurance as possible. We take Medicaid, we take a lot of the Medicaid managed care plans, but it still seems that patients go without the necessary care because they don't have access to affordable health insurance or to physicians within those affordable health insurance plans.
Absolutely. Unfortunately, I think for the majority of physicians, we see this somewhat regularly, is that women are coming forward and really asking for help. And the problem is, even as a physician, I really don't know what the best answer is to that when you don't have the insurance to access these providers. And obviously that's a very complicated issue that there's a lot of debate about as well, with insurance companies and how they affect patients as well as providers. But unfortunately, we see that all the time.
And so, Dr. Bennett, do you work in that dual role at NYU often? That often attendings at NYU have is seeing patients in the private practice setting at NYU and also seeing patients in the public health setting at Bellevue Hospital?
So I do not see patients at Bellevue Hospital, but what's really great about our division is that we span across different hospitals. So we cover a private hospital, we cover a public hospital, and I function mostly out of our Brooklyn hospital because that hospital is really centered in a very diverse community where a lot of our patients actually have Medicaid or no insurance and then get Medicaid because they got pregnant. And so one thing that I'm very proud of, in addition to our implicit bias training and really pushing that forward, is that once you get into our healthcare system, we figure it out. There's no woman that's going to walk through my door and then need a specialist and I'm unable to get her to that specialist. And so I think that's a huge step in sort of making sure that we take care of our moms and making sure that they have access to doctors who they otherwise would not see because of insurance issues.
How do we fix this? I'm sorry. I just had the words had to come out of my mouth. And again, yeah, right, exactly. I know. Like, how do we fix the world's economy and like poverty at the same time? We wish we could, right? No, how do we? So, the question is, geared towards how do we as physicians work within the system, and I think you just pointed some of that out. But how do we as physicians work within our system to offer more global opportunities for systemic change? In other words, how can we be physician activists? How can our patients be active? How can our patients work with us to support some level of, I mean, this all comes down to activism, right? Because I'm personally not friends with any, and I hope I don't know any. I don't know any physician who would think differently than what you just expressed with regard to, yeah, a mom comes to me, they're going to get care, I'm going to get them in, I'm going to get them taken care of, I'm going to make sure they get to the right people. So I think all of the physicians I know, or at least I hope, would share that philosophy. But then there's another, so yeah, there's some problems with physicians, but then there's also the system problem. There's this systemic issue. What potentially can we get involved in, and what can our patients get involved in to help this along? Are we talking about political activism? Are we talking about what are we? I mean, the system's so big, and we feel small, but we don't have to be small.
I think there's a few layers to that, and I wanted to make sure at some point in this discussion, Ken, that I thanked you. So this was my little mini activism when I was thinking, what could we do? And I was thinking about our podcast, and I literally took a deep breath and sent you an email. What do you think if we do this? And I knew it was going to be interesting and complicated, and I think you accepting the opportunity to do this was very encouraging for me, and I think it's ended up being a really productive conversation. So I think on an individual level, we just have to say, I think just speaking up, and eventually what happens is hopefully that means more organization as a group. And, doctors and patients, both are very powerful groups. And I think we just really need to look for those opportunities to organize and speak out to, whether it's to our politicians, to the insurance systems. We really need a more unified voice, and we do have those national organizations in place, and I think really now is the time to take advantage of those. And if we're speaking as a large, very powerful group, I think that's when we're going to see some change.
I want to do part 2 of this. I normally don't want to do a part 2, but this needs a part 2 because we do a ton of great topics. And we could potentially repeat those topics months later. But in short term, I'm gonna ping you again, Dr. Bennett, and we might even need to bring somebody else in as well, like an administrator or a politician, somebody or a public health expert who can help us kind of work through some of these issues. But I don't think we've unwrapped this enough. I'm feeling hungry, like I feel unsatisfied, and if you've been involved in this conversation, even for the last 10 minutes, I hope you feel unsatisfied as well. But we're kind of getting out of time, and we can't do like a 4-hour podcast, and nobody will listen to it. People don't want to listen to I can't get my kids to listen to me for 15 seconds, and generally YouTubers don't want to listen to us for more than 5 minutes. Podcast listeners are a little more attentive. I do want to say, if either of you have anything else to say, please let's do some final words now. I'll have Dr. Bennett go first.
So I think it's really good to sort of focus on what are the next steps. And I think there's a difference between philosophy and actual action items. So on an individual level, I think we can, 1, check your bias at the door. 2, go the extra step for your patients by learning cultural competence. 3, going the extra step for your patient by also advocating for them when they're not in the room. So if that patient needs a referral to a specialist, believe it or not, some doctors will say you need to meet with X specialist, but they don't get them the appointment. So I think that's a next step in using, it's hard for us to do that as physicians, we're taxed with so much, but our ancillary staff can help us just actually plug patients into these specialists and referral centers that they're being sent to. I think our voice is also very strong. People cannot see you right now, Dr. Levy, but I'll just put it out there. Dr. Levy, for those of you who have never seen his face, is a white male presenting person. And I think it's important that people like you are speaking up and using your voice to amplify the voices of minorities, especially minority women, especially when we're not in the room. And I think those are individual things that we can most certainly do. in addition to calling our local officials and using our voice politically, filling out our census and encouraging people to do that, because we know that a lot of this is going to come from money. And so I do think that as individuals, we can use our voice in a political way to make sure that changes are occurring on a legislative level.
Yeah, thank you. Thank you for your comments. I didn't tell you to. I didn't tell either of you at the beginning that while you guys can only see each other, the YouTube audience can see all three of us. So I appreciate that. That's great. But yeah, and then to your point, Dr. Bennett, right? There are other things we do, and if you're in medicine that allow patients to get better care, care coordination is one of those big pieces that is really super important. Dr. Dada.
I think this is a really exciting time for medicine. I think there's a great opportunity here. I think we are past the point of needing to accrue evidence, whether there are disparities that go beyond access and socioeconomics, and it's time to acknowledge that we all have to play a role, that we are all playing a role up to now, and now we have to play a positive role in how to affect that. And I think that starts at the individual level. And I think this is, time to take the opportunity to have those very difficult discussions and really acknowledge that we need a systemic change and how we can be part of it. And again, like I said before, the stakes in this particular arena are people's lives, and there's no better motivation. And I think this is a really important time for medicine and history in general.
I like that you pointed out that we don't need more data. We don't need another study. We don't need another committee. We need an action council. We need people who are going to say, okay, this is what needs to be done. This is how we're going to do it, and then we can follow up. Then we can follow and see how those programs work. So I thank thank you, Shoma, for offering this up as a topic. Thank you very much, Dr. Bennett, for all of your expertise. It is an absolute pleasure to see someone that I've known since their intern year achieve so much and get to the level that you've come to, and have such an incredible level of knowledge. That warms my heart, and I know that everyone at NYU is proud of you. This has been Women's Health Weekly. Thank you very much for listening. Thank you very much for joining us. We will have this as a podcast. Please listen to our podcast on Spotify and iTunes and anywhere else you might listen to podcasts. We're all over the place. You can follow up if you've missed our telecast today. Certainly you can see it on YouTube as it will be up, and we do break it up into clips later on so that you can see specific topics in smaller clips. Thank you very much. We will do this again, and we will invite Dr. Bennett back and Dr. Dada back. I hope everyone has a very pleasant weekend. Stay safe and be well. Thank you very much.
Thank you, Dr. Levy.
Thank you.